Thank you, Jess. Good morning, everyone. My name is Christy Allen. I'm a Knowledge Translation and Implementation Coordinator with the Waypoint Research Institute, and very happy to be with you this morning for our October Waypoint Talk session. This is mobilizing evidence for mental health decision makers with folks from our Stream Lab. We want to start with a land acknowledgement. The Waypoint Research Institute is located on the traditional territory of the Anishinaabe, which include the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee, Huron-Wendat, and Métis people. We acknowledge and affirm our commitment to improving relationships between nations and to improving equity for Indigenous communities residing in the central north region of Ontario. So welcome to Waypoint Talks. This is a virtual webinar series hosted by the WRI, where we highlight the practical implications of research projects. This may be more similar today, though, to our series, Building Your Research Toolkit. So we aim to highlight best practices used in mental health research, quality improvement, and program implementation. And these events are open to all who are interested in learning about emerging research, best practices, and clinical innovation. Few housekeeping notes. So this is hosted as a Zoom webinar, so please use the chat box in the Q&A function to connect with speakers and fellow attendees. I believe our team today would like you to use the chat and interact, and they'll cue that. And there will be dedicated time at the end of the presentation for questions and discussion. So feel free to add to the Q&A box throughout. The recording and slides will also be available post-event on our website, and we ask that you complete our post-event survey. This helps give us feedback and improve our future Waypoint Talks events. There's also attendance certificates for professional development available, and we'll share how to access those at the end of the presentation. So let's introduce today's speakers. Dr. Kara Evans is the Manager of Knowledge Mobilization with the Stream Lab. She holds a PhD in health policy from McMaster University and is particularly interested in intersections of service user perspectives, research evidence, and health system decision-making. Kara began her career as an occupational therapist in the field of mental health. Maren Guide joined the Stream Lab in May as a research analyst, and her role focuses on supporting the collection and analysis of mental health and addiction data for evidence reviews. She brings her background in primary care and public health research. And last but not least, Irina Bogdan joined Waypoint as a Knowledge Translation and Implementation Coordinator in 2022, where she supports knowledge transfer and exchange efforts through the Stream Lab. With a background in nursing and public health, Irina has a passion for making complex information accessible to various audiences and has extensive experience in health education. So that's enough from me. I'll pass it over to the Stream Lab for today's presentation.
Hello, thank you so much. Let me just pull up our slides on screen. All right, can folks see that all right? Perfect. Well, thank you so much for having us here today at Waypoint Talks. We're really excited to get to speak to you about mobilizing evidence for mental health and substance use system decision making. As mentioned, my name is Kara. I'm here with my colleagues, Irina Bogdan. Maran Gaidi is having some technical issues, but hopefully our third presenter is able to hop on the line. We are looking forward to telling you a little bit about our team, about what we do, how we do it, and why. We'll walk through a case study example of one of our recent projects and wrap up with some reflections, lessons learned, and next steps for us as a team. So to get started, STREAM stands for Supporting Transformation Through Research, Evidence, and Action in Mental Health. We're based here at Waypoint, out of the Waypoint Research Institute, and we are primarily funded directly by the Mental Health and Addiction Centre of Excellence at Ontario Health. What we do, in a nutshell, is we conduct rapid reviews of research and other types of evidence to address decision makers' questions about health systems. That's a little bit of a mouthful, and we're going to break it down a little bit in reverse order, starting from the end of that sentence and working our way back. So what is a health system, and why does it matter? Ultimately, patients and patient-provider interactions are at the heart of a health system. That's why a health system exists. And those interactions are taking place in a context that's constituted by policies, guidelines, standards, documents, by human resources, technology, funding, by the relationships among organizations within a region or across a province, by the processes through which change is rolled out. And so when we're talking about health systems, we're talking about those policies, resources, relationships, and processes that surround patient care. When those are sort of aligned and working well, they can create space for care to take place in a way that's smooth and patient-centered. And at other times, when elements of a system might be kind of out of joint, they create pressures or challenges. So ultimately, a good health system creates space for good health care to happen. You've probably heard of evidence-based medicine or evidence-based decision making. And policymakers have too. As far back as the 1970s or 1980s, folks in the world of policy started sort of borrowing from the evidence-based medicine paradigm and talking about evidence-based or evidence-informed policymaking. This is a process where multiple types of information, including research evidence, are brought to bear on a decision-making process. And here at Stream, we are helping policymakers create evidence-informed health system policies. Now, there are challenges for evidence-informed policymaking. To start with, policy is never just about evidence. It's shaped by social values, by what the public, the voting public, cares about. It's also shaped by the political party that's in power at any given time and kind of setting the policy agenda. Policies are influenced by interest groups that are advocating for a particular community or a particular approach. And policies are also really influenced by what's already in place. It's really hard to build a system from scratch. So a lot of time, policymaking is more about patching up and building on what we already have. So that sort of constrains the options that might be available. It's also important to note that research-based evidence can be used in policy in varying ways, and some of them are maybe more productive than others. So evidence can be used to solve a policy problem. If we want to increase vaccine uptake, we can look at the research and see what strategies there are for increasing vaccine uptake. It can also work in a slower and more subtle way through changing the way that people think about and talk about a particular topic or issue, just changing the discourse. As an example of this, we can think about the idea of harm reduction in substance use policy. Harm reduction was not invented by researchers, it was invented largely by people with lived experience and by advocates. It was broadly taken up in research, and as a combination of lived experience advocacy, ongoing research work, and other factors, this has sort of shifted the discourse around substance use. So any policymaker talking about substance use might talk about harm reduction without citing a particular research study. It's just now part of how we think about and talk about this issue. Now, sometimes evidence gets used to delay decision making, and you've probably seen this happen where policymakers are like, we need a commission, we need an investigation, we need to find more data. And like, absolutely, sometimes we do need a commission, an investigation, and to find more data. And sometimes maybe that's kicking the can down the road a little bit. Sometimes evidence even gets used to justify a decision that's already been made or a stance that's already been adopted, which sounds sort of like somebody being like, can you find a study that says such and such? So there are pitfalls and there are challenges, and there are also really important opportunities introduced through an evidence-informed policymaking paradigm. Policy is never just about research evidence, and an evidence-informed approach brings research into that conversation so that we can be learning from evidence about what works and how and in what contexts. This promotes good resource stewardship. If we are investing our money, our time, our effort, we might as well put that money, time, and effort into what's likely to work. And ultimately, an evidence-informed approach can help us achieve aims that are aligned with social values. Evidence doesn't tell us what the goal should be. But once a direction is sort of chosen, again, maybe that example is we have a goal of increasing vaccine uptake, evidence can show us how to get there. But how does the evidence get to policymakers? How do they find it? How do they get their hands on it when they are trying to make a particular decision? The concept of knowledge translation is about bringing research evidence out into the real world of practice. And in its earliest iterations, knowledge translation sounded a bit like we, the researchers, will bring you, the knowledge users, evidence in a forum that you can use. So instead of writing a paper that's going to be paywalled and maybe read by 5 people, we will also make an infographic, make a toolkit, make something that actually can help that evidence be put into practice. In further iterations of knowledge translation, this has evolved, including into an approach called integrated knowledge translation. So that means that rather than just tacking this on to the end of a study, we're like, okay, how do we neo translate what we've already found? Integrated knowledge translation is about working with knowledge users through the whole research process, right from the start. That can sound a bit like we, the researchers, will work with you, knowledge users, to figure out what questions to ask and where we might find some answers and how to present those findings in a usable way. Now, one particular policy-focused approach to integrated knowledge translation is done by teams that are called evidence synthesis teams or evidence synthesis units. This is a demand-driven approach to knowledge translation, meaning the questions are coming from users, designed to address policymakers' evidence needs in a way that is structured, transparent, and timely. Here, what that sounds like is we, the policymakers, need you, the evidence synthesizers, to tell us what the research says about this issue by next Tuesday. So it's about working on the timelines that policymakers need with an approach that's transparent so it's perceived as trustworthy rather than advocacy. Um, and there's been a lot of uptake of this approach of evidence synthesis units or evidence synthesis teams. There are teams across Canada and actually all around the world that are taking this demand-driven approach to integrated knowledge translation, including us here at Stream. We are an evidence synthesis unit joining these other units around the world. If you are maybe wondering why and how there happened to be an evidence synthesis unit here at Waypoint, the answer is a little bit of serendipity. Our previous Vice President of Systems and Partnerships at Waypoint, Dr. Heather Bullock, had spent some time in the evidence synthesis world, and she identified a need for those kinds of supports for mental health policy implementation in Ontario. So she got this program sort of up and running back in summer 2023. On the screen, you can see our current team. We right now have executive sponsorship from Nadia and are a small but mighty crew of 4 staff. Oh, that is not the slide I meant to be on. Sorry, folks. You now get a preview of the whole presentation while I get back to where we just were. Okay. So what we do here at Stream following the commercial break, we develop evidence products for our partners. Again, most frequently, that's the Center of Excellence. We can work on timelines that range from 3 days to a really urgent and high-level overview to 8 weeks or more for something that goes into a little bit more depth and detail. We focus on mental health systems questions rather than questions about, say, what medications should be funded or what therapy should be used. Again, we're looking at those policies, resources, processes sort of questions. Most typically, the output of our work is a report that is designed for a policymaker audience. We do also sometimes put forward other types of evidence products like tables, infographics. We've convened a dialogue to advance movement on next steps in relation to a particular topic. And while our core task is often focused on research evidence, we do also include other types of evidence. This can include expert opinion, gray literature on what other programs and projects are doing to help us kind of put that evidence into context. Oh, goodness. Sorry, having some slide trouble. All right. So I'll walk through the process briefly of what one of our evidence reviews looks like, taking first an example where we're just using academic evidence. This starts with receiving a request from decision maker partners. So folks within different teams at the Center of Excellence might reach out to us and describe a topic where they're interested in knowing what the evidence has to say. Our next step is to write up a brief proposal, typically 1 to 2 pages, where we take that topic and turn it into a searchable question. We develop a strategy that we're going to use to search for an answer to that question, define sort of the scope of what's in or out, and a little bit of an outline of what our ultimate product will look like. And there's sometimes some back and forth this stage, where consistent with an integrated knowledge translation approach, we will get back to the folks who made this request and work with them on that proposal until we're all on the same page about the question that needs to be answered and how we're going to go about doing it. And then we go out and we look for some information. And often we're using academic databases and running a structured search where we've developed some keywords in advance. We put that into the database and it will pull up often hundreds of articles, but only some of those are relevant. So as a team, we work through those articles to find the ones that are actually related to the topic that we're looking into. The next stage of the work is called data extraction. This is where, now that we've narrowed down to the articles that are actually relevant, we've got to pull out the relevant bits of info from those articles. We create a structured table, usually using Excel, to do this, and work through the articles, taking out the information that we need. And then we synthesize this, meaning we make something out of it. We find some common themes or common elements and pull it together into a report or another product, share that back with our partners. And again, the journey doesn't end there because this is an integrated approach. They might have some questions. The evidence doesn't change based on the questions that they ask, but we might be asked questions about clarifying a particular finding. There might be a request for some follow-up searches or some key informant interviews to contextualize what we found. As noted, the process that I just walked through is specific to when we're doing a literature review, but we do sometimes at different points in this process tap into the wisdom of experts in the field, which might be clinicians, leaders of lived experience advocacy organizations. We sometimes do a scan for other programs or other jurisdictions doing similar work, or look for sort of published reports, program evaluations. That type of stuff is called gray literature, to round out our findings. So with that, I'm going to pass this over to Arena, and depending on the status of tech issues, possibly Maron, to walk you through an example of our work.
Thanks, Kara. And yeah, Maran is here. Hooray. So we've covered some of the background. Now we're going to shift gears and dive into a real world example using one of our reviews on the use of artificial intelligence or AI as a case study. So we'll start by giving you a bit of context, and then we'll take you step by step through that rapid review process that Kara just laid out, from the initial request all the way to synthesis and final reporting. So to keep things interesting, each stage of the process will be presented in 4 parts. So Maron will start by introducing the step itself, explaining what it involves, and then I'll pause the story for what we're calling a speed bump. And this is where I'll ask you to think about what challenges might come up during that step and how you might handle it. We'll go back to Maron, who will share the mitigation strategies that we actually used for this specific product. And then finally, we'll wrap up each step with a quick multiple choice, again, led by me. So we'll move through this rhythm of overview, challenge, mitigation strategy, and review question for each step of that review process. And every time you hear my voice, be ready to engage. I want to see your fingers typing. And with that, I will start us off with a bit of context. Next slide, please. Recently, there's been a lot of ongoing to explore the use of AI to help optimize processes and improve patient care at Waypoint. You may have heard of some of these. Some of the efforts do include AI-focused research projects, the development of an AI adoption roadmap and governance plan, education and skills building opportunities to help staff and patients understand what AI can and cannot do and how to work alongside it. And of course, the AI community of practice led by data analytics, where staff can share ideas, resources, and lessons learned about AI. And also shout out to that team because that's where I got the inspiration to include little multiple choice questions throughout the presentation. And Stream was able to support one piece of that larger puzzle by producing a rapid review product focused specifically on the use of AI in mental health care. Now I will pass it off to Maron, who will talk to us about the first step in our process.
Thank you, Arena. Yeah, so with the first step, we have the requests. So we connected with a Waypoint team exploring AI within mental health settings, and some areas of interest for them included AI for summarizing electronic health record documentation, decision support, direct patient interaction, resource navigation, and improving communication between care providers. Back to you, Irina.
And that takes us to our first speed bump. So we just talked about that initial moment when a partner comes to us with a topic of interest. And I want to ask y'all, do you foresee any challenges with this step? And feel free to type your answers into the chat box. I'll give you a bit of time to think about it. Privacy laws, yeah. Yeah, Kara, can you go to the thanks. hmm Being aware of patient interest acceptance. Kindness with patients, yeah. Any challenges you see with the process itself? Shared understanding of AI, totally. Black box of AI related to decision making. Yeah, we don't necessarily know how AI is making those decisions or coming up with its responses. Very broad range of topics makes it difficult to identify a research question. It's a new thing, limited evidence. Totally, yeah. So the some of the challenges that we've highlighted here are too many questions, and the questions are really, really broad. So I'm going to throw it back to you again. What are some mitigation strategies that we can use for these specific challenges? So when there's a lot of questions that are broad, what can we do about that? Narrow your intention, totally. Pick a population to focus. Yeah, yeah. Narrowing that down again, touch base with stakeholders again to understand their key priorities, identify priorities. Exactly. Yeah. So I'm going to toss it back to Maron, who will explain what we did for our product.
Thank you, Rena. And thank you, everyone, for being so engaged and providing a great bunch of answers. Yeah, so to resolve this challenge, we clarified the needs of our partners, conducted preliminary searches, and narrowed our scope. And back to you, Irina, for the review.
Sweet. As promised, we will wrap this first step up with a quick review question. So here's how it's going to work. I'm going to read the question and answer options out loud. I'll give you a few seconds to think of your response, type it in the chat, and then don't hit submit yet. I'm going to count down from 3, and then everybody hit submit at the same time. Cool? All right. The first question, what could you do if partners come to you with several different topics or research questions for one rapid review? And this is a select all that applies, so there might be more than one correct answer here. A, conduct preliminary searches to see what type of literature is available. B, choose one topic and ignore the rest. C, help partners narrow their ideas into one clear question. Or D, address all topics in one review. So again, I'll give you a couple of seconds. Don't hit submit yet. I'm going to count down from 3. Okay, it seems like everybody knows. So 3, 2, 1, go for it. All right, I'm seeing a lot of people saying C, which is help partners narrow their ideas down into one clear question, which absolutely we do that, and we'll do that through a meeting most often. And then I'm seeing a couple of A's as well, which is conduct preliminary searches to see what type of literature is available, which we will do just to see what's out there and what the literature might actually cover. So yeah, the correct answers are A and C. B, choose one topic and ignore the rest. We wouldn't do that without talking to our partners as they know their priorities best. and D, address all topics in one review. That could get really overwhelming really quickly and make it less manageable for a rapid review. So awesome. Thank you so much for your participation. Any questions on step one before we continue? And you can put these in the chat as we're rolling, and we'll maybe I'll pass it to Kara to answer any questions in the chat. But Maron, on to step two.
Thank you, Irina. Step two, the proposal. So after narrowing our focus in collaboration with our partners, we landed on the following research question that you see on the slide. So basically, how AI is being used for mental health and substance use assessment at various points across the care continuum. So including at intake, during triage, and during transitions of care. Next slide, please. We then developed a proposal. So as Kara mentioned earlier, this is our next step. And as shown in the slide, we outlined in this proposal the topic focus, the research question, the search terms that we plugged into the academic databases, our inclusion and exclusion criteria, our expected output of evidence gather, which was a report in this case to best address our question, as well as examples of the types of papers that we're finding, and the expected timeline. So it was about 6 weeks for this project. Over to you, Irina, for the speed bump.
All right, speed bump number two. So part of developing a proposal includes trying out different search strategies, figuring out what keywords we might use, different combinations of those databases we might look into. So do you foresee any challenges with this step? And again, just type it in the chat. Any challenges with trying out different search strategies? What might happen? All right, new topic for folks. That's all right. Some of the challenges that we'll highlight in all, there we go. Too few results. All research terms in English, use other languages. Yeah. Conversely, too many. Exactly. Yeah. Those are the two big ones that we wanted to highlight. So sometimes you have two, or oftentimes we have too few relevant articles just because we work on broad system level questions. So there's not a lot of literature out there oftentimes. Every once in a while, we run into way too many articles. So for either one of these situations, what might be some mitigation strategies? What might we do? Will the slides be shared after the presentation? I believe so. I think there's a recording that's going to go up on our website. Keywords can have multiple meanings depending on the context. Yep, absolutely, which can bring up a lot of what we call noise. So a lot of unrelated papers. If there are too few, broaden the search, redefine the search terms. If there's too many, focus the search even more. Yep. Time frame limit. Yep, we can expand that or narrow it down. Awesome. Thank you. So I will pass it to Maron, who will first talk about what to do in the case of too few relevant articles, in the case of too many articles, and then what we did for this particular product.
Thank you, Irina. And thank you everyone again for those great responses. Yeah, so in situations where there are too few articles, consider adding search terms, including single studies rather than limiting your search to structured reviews, expanding the date range, including other forms of evidence like key informant interviews to gather insight and evidence from knowledge experts, or include great literature such as policy or government documents. Or also you can report on what is known and be transparent about the limitations. And in situations when there's too many articles, consider removing the broad search terms, including structured reviews only, narrowing the date range, or the scope. Next slide, please. Okay, and in our case, where we had too many articles, so what we did is we removed the broad search terms. We included structured reviews only. We narrowed the date range the past 2 years and narrowed our scope. So we focused on applications for mental health assessment in clinical settings only and excluded papers where the AI was trained solely on biomarker, neuroimaging, or social media data. Now over to you, Irina, for the next review question.
Great. Okay. Review question for step number 2, same process. I'm going to read it out loud. Type in your answer, but don't hit submit yet, and I'll count down from 3 and we'll all submit at the same time. So if you conduct a search that yields very few relevant studies, what might you do to address the evidence gap? A, stop the review and report that there is not enough evidence. B, expand the search to include gray literature and/or expert input. C, repeat the same search in the same database to try to find more results. Or D, extend the search time frame indefinitely until more studies on the topic are published. Okay, so type it in, don't hit submit. And ready? 3, 2, 1, go. B, yeah, I'm seeing a lot of B's, which is expand the search to include gray literature and expert input, which is exactly what we do. Sometimes topics are just not super well addressed in the literature, as we've said, and sometimes it's we can get more detailed descriptions of what's happening through evaluation reports, government documents, or just by talking to people who know the field very, very well. In terms of the other options, stop the review and report that there is not enough evidence. We won't just stop the review, but we might be very transparent about the fact that there's not a lot of evidence on this topic, and we'll report on what we can. C, repeat the same search in the same database. That's just going to get you the exact same results, so we don't do that. And then D, extend the search time frame indefinitely because we're doing rapid reviews and people need this information on very quick timelines. We can't do that either. Sweet. If there's any questions about step 2, feel free to put them in the chat. In the meantime, Maran, off to step 3.
Thank you, Irina. Step 3, screening. So after receiving our feedback from the knowledge producers or knowledge users and adjusting our proposal accordingly, we ran our search terms into academic databases to retrieve results. And we then began the screening process of reviews using a systematic literature search tool called Covenants to help facilitate this process. And during the stage, 2 reviewers independently applied our inclusion and exclusion criteria to each paper as outlined in our proposal and voted on whether to include or exclude it in our report. And this often involves 2 stages, so the title and abstract review, as well as the full text screening.
Great. So another speed bump. After we completed the screening, we still had 55 papers left to extract. So do you see any challenges with that? Type it in the chat. Time consuming. Yep. Yep. Exactly. 55 papers is quite a bit for a rapid review. So one of our big things is feasibility concerns and how much we can actually do within a short time frame. And one of the other challenges that we saw come up is that may start to capture data that is less directly relevant to our partners' needs and questions. So it might be worth narrowing down our scope further. What are some mitigation strategies we can use here? And I gave away the answer a little bit, but narrow the exclusion criteria. Yeah. Narrow it down further. Yeah. And I'm going to pass it back to Maron, who will explain how exactly we narrowed it down without killing the quality of our review.
Thank you, Irina.
Yeah, so what we did to narrow down our focus is we carried out a mapping or mini extraction of the 55 papers to identify groupings of papers that were less relevant to our scope. So basically, as you can see pictured on the slide, in this simple table, we pulled out information related to the article characteristics, the population characteristics, the type of data inputted into the AI model, as well as findings, limitations as well from the abstracts. And over to you, Arena, for the next review exercise.
Great. Okay, next review. When screening literature for a rapid review, which of the following actions is appropriate to consider? A, use clear inclusion and exclusion criteria to guide screening decisions. B, exclude studies that have negative or inconclusive results. C, stop screening once you find 50 relevant papers. D, have only one person screen all articles to streamline the process. I'll give you a few seconds to think. And ready? 3, 2, 1. A. Yeah, okay. This one was an easy one. Yes, we will apply that inclusion exclusion criteria to see which ones we will vote to include or exclude in our final review. The other three options on screen there, they might seem like time savers, but they can actually make a rapid review less reliable by excluding key studies or introducing bias. Okay. Next up, step 4.
Thank you, Rena. Step 4, data extraction. So upon further discussion, we decided to exclude all papers that included any data that was not of relevance. So for us, this meant studies that used AI trained on neuroimaging, biomarker, or social media data, which was less relevant to our knowledge users. And the second round of limitations left us with 13 reviews for full text extraction. And what this means is this involves us pulling the relevant bits of information from each review according to these categories and presenting it in a clear and visual table. So as you can see on the slide, what we pulled from each of the reviews was information related to the articles, data inputs, technological performance, and predictive validity, findings, as well as limitations. Back to you, Arena, for the speed bump challenge.
Amazing. While we were pulling key details out of each study, we did run into another speed bump. And for this particular review, none of the stream team members were experts in the field. So none of us are experts in AI. And before we tell you how that played out, pause for a second. And do you foresee any challenges with the situation? Yeah, understanding what key details to extract when not familiar with the topic might miss important information. Perfect. Yep. Not fully knowing the relevant terms and understanding. Exactly. Yep. Yeah, so some of the challenges that we're highlighting here is there might be potential confusion among team members about what exactly to extract, especially when there's topic-specific terminology or even study designs. Inconsistencies in extraction, so different reviewers might interpret the same information in different ways if we're not clear on what we're extracting. And we could even extract the wrong data, which might happen if we don't fully understand the technical nuances. So I'll throw it back to you again. What are some mitigation strategies that could be used here? Yep, team members develop a shared understanding for sure. Do some contextual research to understand the terminology and important information, consult with expert, have support of an expert to define key terms, tapping other experts to assist. You guys are geniuses. Exactly. I will pass it back to Maron, who will describe our approach to this.
Thank you, Rena. Yeah, so what we did in this case is that we ran a pilot extraction and developed a typology in consultation with our partners, as you can see on the slide, to support a shared understanding of machine learning approaches, which is some of the responses that you guys shared. So awesome. Back to you, Irina.
Amazing. So the question this time is, which of the following are appropriate actions when it comes to data extraction? And again, this is a select all that apply. So there might be more than one correct answer. A, ask experienced team members or partners for guidance before starting, especially if you're not an expert in the field. B, extract every detail from each study just to be safe. C, only extract data from studies that support your assumptions. Or D, conduct a pilot extraction and discuss as a team. And 3, 2, 1. A and D. Yep. Yeah, exactly. No worries. Perfect. Yes. So the correct answers here are A and D, which is exactly what we did. In terms of B, extract every detail from each study to be safe. We won't do that because that could be very time consuming and get us data that's not super relevant to our review. And for C, only extract data from studies that support your assumption. Again, this might bring in biases and make our rapid review less reliable and true to the literature. Um, so back to Maron for synthesis.
Thank you, Irina. Yeah, so step 5, synthesis. So we then synthesize the data from the included reviews into a 22-page report. And as you can see on the slide, it entailed our primary research question as the title, the table of contents, key points of this paper, so highlighting the key findings under each of the subsection, a methods page, which detailed our search strategy, as well as findings according to clinical data AI inputs and wearable data AI inputs, equity considerations, limitations, so in the evidence base as well as our approach with our search, and considerations for decision makers were also identified. And then lastly, we have the appendices, which includes more details about the methods, our reference lists, and data extraction spreadsheets.
Sweet. So we're actually going to skip a speed bump here and go into our last review question. When you reach the synthesis stage, what is the most appropriate way to handle the information you've extracted? A, report every finding exactly as written in each study. B, exclude studies that do not agree with the majority of findings. C, summarize and organize findings according to key themes. Or D, write in narrative format only, avoid using bullet points. So I'll give it a second. And 3, 2, 1. See, yeah. Yeah, so we'll summarize and organize findings according to key themes. In terms of the other options, A, report every finding exactly as written in each study. Again, this is a bit of a regurgitation of the articles, and what we do is synthesize everything to make it useful for the knowledge users. B, exclude studies that don't agree with the majority of findings that will introduce biases and make our paper less reliable. And then D, write in narrative format only. We actually use bullet points and tables all the time to make our reports more easy to read and user-friendly and more helpful for our partners. So yeah, C is the correct answer. Thank you. And last time, Maron, back to you.
Thank you, Irina. Yeah, so the last step is the submission and follow-up. So we then share back our draft with our partners. We received their feedback and then implemented those changes. And we are now working on a 2-page graphic summary, which will be posted on our website later this year. So stay tuned for that. And over to you, the wrap-up section, Kara.
Thank you. Yeah, so we're going to wrap up with a little bit of what we've learned from the first 2 and a bit years of Stream's operation. In that time, we have completed dozens of these products. So some of the topics that we've covered to date have been reducing mental health and substance use related emergency department and inpatient care utilization, engaging people with lived and living expertise in policymaking, approaches to delivering substance use services in rural areas, perspectives on client experience measurement, and components of a comprehensive crisis care system. In another plug for our website, summaries of these topics will be currently online. So you can scan that QR code or find us on the Waypoint website. If you haven't noticed, we're really excited that we have a website with some of our products up. In these 2 years of work, we've learned some things about the work that we do and the context in which we do it. One lesson learned that I think became clear for us pretty early on is that policymakers and researchers ask different questions. So, in an example of this, one of the early topics that we were asked to look into was the elements of a continuum of care for people with multi episode psychosis. So, what would need to be in place for somebody, regardless of where they are at in their wellness or in their recovery journeys, that we've covered sort of all the levels of intensity, acuity, severity. And it makes total sense from a policymaker perspective that you'd want to know what are all of the pieces of a system that we need to have in place, from primary care through to like really specialized services. Researchers, though, they haven't looked at it in this way. We didn't find papers that straight up described the full continuum of care for multi-episode psychosis. We found a lot of papers focusing on one specific intervention at a time. So a paper about flexible assertive community treatment or a paper about intensive case management, but not necessarily linking all of those pieces together. And this kind of rears its head again and again as we receive questions from policymakers that are totally sensible in the context of planning and implementing policy and challenging to address from a research standpoint. In these contexts, we try and find sort of a way in through the way that we frame the evidence, as well as presenting the gaps in what's known, that sometimes these questions haven't been addressed through a research point of view. Also, broadly, the literature is full of uncertainties. It's full of gaps. Policymakers want us to tell them what works. And often our reports and the literature sound a lot more like, this intervention might achieve this one outcome, but we're not super sure that it achieves this other outcome. And also, a lot of the studies out there are a little bit sketchy or aren't of the greatest methodological quality. So often we're reporting on these uncertainties, on these gaps, or on these sort of mixed findings across different outcomes. This is particularly true in relation to health equity. In every report that we do, we summarize what's known about the health equity implications of a particular intervention or of the topic. But a lot of times there are big gaps in the literature related to, say, differences in outcomes across populations from a particular intervention. We also know that multiple forms of evidence matter. So again, most often we're summarizing the state of published research evidence. And sometimes bringing in other types of evidence shifts the picture. In an example of this, we did a report that was looking at use of video conferencing or phone for psychiatric assessment in rural and remote hospitals, where they might not have access to a psychiatrist. And if somebody comes in some sort of mental health crisis, we're like, could we safely do assessments remotely? And the academic literature was concerned with the accuracy of assessments conducted in this remote manner. We also proceeded beyond summarizing that literature to talking to clinical experts, including in rural and remote hospitals. And what they were worried about was less about the accuracy, but more about what happens if particular assessment decisions are made and they might not have the resources to follow through or to get somebody in a prompt manner to an appropriate service setting. So it shifted the meaning of what we found and introduced whole new questions and whole new sort of policy dilemmas when we gathered that expert insight to understand what this looked like in context. We also know that flexibility and transparency are both really important. In a traditional academic review, transparency is king. You might publish in advance your protocol that says these are the terms we're going to use, these are the databases we're going to search, here's every step of the way that we're going to follow. And the reason that setting that out in advance is important is so that people can trust the findings. They know that you aren't cherry picking the studies that said what you were hoping they would say. You're not doing that decision-based evidence-making thing. And so we do, borrowing from these approaches, create proposals in advance, determine our keywords or inclusion and exclusion criteria in advance. And sometimes we get into the literature, we get into the weeds of it, and we find very little. For example, we find that the criteria we set out leave us with nothing to work with, or are pulling up things that are really not relevant. So in order to meet our objective of addressing policymakers' evidence needs, sometimes we need to be flexible as we go. So as Marilyn described, we might pull together a really quick summary of the state of the evidence and say what parts of these are relevant to you and what parts of it aren't, so we can focus appropriately. We might introduce additional searches or additional key informant interviews. And then this loops us all the way back to transparency. We need to really clearly describe how we departed from our initial plans, what we introduced along the way. In order for policymakers to continue to trust the work that we put forward, they need to see it as sort of a like quote unquote neutral summary of the evidence that exists out there. So that transparency is a big part of how we earn and maintain that trust. Finally, a key lesson learned is this really is a team effort. We absolutely could not pull off the timelines that we do, for example, without our whole team. We draw on a range of skills and knowledge areas across the team. And also sometimes we're just like all hands on deck. Everyone is screening and extracting articles because we got to get this done. Some of where we hope to go from here. Our first couple of years were really spent getting our bearings, establishing ourselves with our primary partner of the Center of Excellence. And now that we have a little bit more solidity in our processes and in our team, we are looking to integrate ourselves within the organization, within the broader mental health system. Connecting to additional partners, for example, and sort of putting ourselves and our name out there. We're also hoping to loop into the broader evidence synthesis ecosystem. So as I mentioned back at the start, there are lots of teams doing this sort of work across the country and around the world, and we want to connect to our evidence synthesis colleagues. One way that we're doing this that we're excited about is we are part of a grant-funded network called the Evidence Synthesis Network for Canada to support pandemic planning and response. This is being led by an evidence synthesis unit at McMaster called the McMaster Health Forum. It convenes a whole group of evidence synthesis units across Canada to carry out work related to planning for future pandemics. And there are teams there that have all sorts of areas of expertise like public health and infectious disease, and our team brings a mental health systems lens. We're also looking forward to sharing our findings more broadly. Another plug for our website. As I mentioned, we're jazzed about it. And identifying opportunities to expand the types of evidence that we access and the products that we create. So broadly, our takeaways for you, thank you for joining us for this presentation. Who we are and what we do, we take a demand-driven integrated knowledge translation approach to support evidence-informed health systems policymaking. And in doing so, we're using collaborative, transparent problem-solving approaches to enable us to produce products that are both rapid and also relevant. And we continue to learn and grow, and we're looking forward to establishing new partnerships and processes. So thanks so much for your time and for your participation, and we welcome any questions that you may have.
Thank you so much. That was great. And so nice to see everyone participating in the chat. So thank you to our audience as well. You can add any questions to the chat or through the Q&A function. So we'll give folks a few minutes to add those in. But maybe I can start with a question. So I'm curious if, and you can each answer this, but if there's a product, you can either speak to one that's been your favorite to work on or one that you found challenging and how you kind of work through those challenges. So maybe we'll start with Arena.
Sure. I have a favorite. It will probably always be my favorite, but we did one on engaging people with lived experience in policy and system decision making. That one was a lot of fun to me because we did get to do a ton about it. So it was the first time, I think, correct me if I'm wrong, Kara, I think it was the first time we did Q Informing interviews. We did gray literature searches for it. We did the academic literature search for it. So it was a lot of different types of evidence. And we got to speak to leaders in roles of words, lived experience roles. So that one was fun. And we did an infographic for it too, which art is my passion. Kara?
Sure. I think my favorite is the one that I mentioned about remote psychiatric assessment. I think that the questions that were raised when we took our literature out to key informants in different areas of the province were so fascinating and raised so many like ethical concerns. Yeah, so it was neat to see the way the meaning of evidence shifts when you put it into context. And I appreciated that we got to do sort of both the initial evidence search and that sort of contextualization piece. I also think a lot of literature doesn't always highlight sort of rural, remote, and northern considerations. So I like that we got to really zero in on that for that product. Over to you, Maran.
Yeah, favorite project. I would say probably there's this one project that we're currently working on. There's multiple parts related to it. So it's a primary care product. And just because there's so many partners that we're working with, and the fact that once we completed a report, there's still opportunities to develop additional products, such as an opportunity to interview with different individuals, as well as creating a two-pager summary document related to the report. So it's nice to see that once we completed that report, there's still lots of moving pieces and other aspects we can continue working on it with that.
Mhm. Wonderful, thank you. And I'm not seeing any questions, but some really nice feedback in the chat. And I just wanted to highlight one comment from Jolene, just emphasizing that the products that you folks create in such short timelines are really wonderful. And so maybe I'll just ask you briefly to speak to that. I know you gave some great strategies throughout your presentation of how to work with quick timelines, but is there anything else any of you want to add about the rapid nature of this work and some tips or tricks to kind of keep things moving along at a quick pace?
Yeah, I can try to speak to that in addition to the considerations that Irina and Maran spoke to. Um, we do adapt standard review methods in order to take a rapid approach. For example, in a standard systematic review that you would find published in a journal, two people do data extraction, and then you compare and make sure that it is the same. We have one person do data extraction, and we'll do a pilot first to make sure that we're on the same page, but to kind of reach our turnaround times, that's sort of a feasibility issue. In standard systematic reviews in the literature, they'll conduct what's called a formal quality appraisal, where every study that's included, they'll typically two people will evaluate whether that is a study that's been done well and is trustworthy. And that's like super important information, but again, it's not necessarily feasible for us within a couple of weeks. So we tend to more broadly highlight quality concerns that we noticed, or sometimes that are highlighted by the review authors themselves, where they might be like, there's not that much in the literature, or the studies in the literature are kind of weak. But we do cut off that like formal quality appraisal phase. In the specific product that Rena and Maran highlighted, the knowledge users actually asked us after the fact, they're like, that information actually would be super helpful. So we went ahead and did that, but it's not part of our standard process. So there are pieces that we leave out of what a more rigorous review would include in order to really focus on our like ultimate mission of getting the key evidence into the hands of folks who use it on a timeline. It does, yeah, it does sometimes mean sacrificing these quality pieces or some of the like context and nuance that you might want in a really rich review, where we'll say we're going to give you the big picture and trust that they will zoom in on the parts that they need to, or come back to us with a more focused question, which does sometimes happen, and we drill down further. Yeah, these are some of the ways that we keep it moving, in addition to just having the luxury of a team that is fully devoted to rapid reviews. So we are able to just go all in. Sometimes if something's really time urgent, we'll be like, okay, drop everything for the next 3 days. All we are doing is answering this one question.
That's great. Thank you so much, Karen. I think that actually ties nicely into Zoe's question. So, do your partners ever expect you to make decisive recommendations about how they should proceed? Um, is this something that you do, or how do you navigate this if this question comes up?
Yeah, thanks so much for that question. we don't make decisive recommendations. So from my perspective, our role is to report on what's out there in the literature, and policymakers get to choose what they do with it. We often highlight considerations where we might sort of flag, given what we know about the Ontario health system, here are some things we think you might want to take into account, how this would link into existing resources, or a need for rigorous evaluation because the evidence is not very strong. But broadly, we leave that in decision makers' hands. And I think that that has been pretty well accepted. I don't know that we've ever actually been pushed to like give them a what to do. In fact, it's sort of the opposite, where um, decision makers don't want to feel, I think, boxed in to responding maybe to a particular, like if we made a really strong recommendation that wasn't actually feasible in context or aligned with a broader policy framework, that's not necessarily helpful to them. So I think they're pretty open to the like summary approach that we take.
That's great. Thank you. Mary and Arena, anything else to add to either of those questions? All good?
No.
Okay. Oh, go ahead, Mary.
Oh no, I was just going off of what Kara said. Yeah, we like to create clear, nonpartisan products, and we're really attentive to like how we're writing those products and try to remain like unbiased as possible and just really focus on like reporting the evidence.
That's great. Thank you. I'm seeing maybe one last question here. So the question is around what information is shared. So we have the 2-page summaries of the rapid reviews, but do you ever plan to share the full reports publicly?
Irina, do you want to speak to that one, or I can?
I think for right now you can email us and we're happy to share those products with you. I'm not sure if we'll have them on the website or not though, Kara. That's
Yeah, the plan at the moment is we'll put up summaries, and folks who are interested in the broader one, like the full report, can email us and request that. I'll also note that we're sharing a selection of the work that we do and not the entirety of the work that we do. Sometimes as things kind of wend their way through decision-making processes, we might be asked um, not to share those findings just yet. So we'll have a few of those summaries. And if there's a summary available, you can feel free to email us for the full report.
Awesome. Thank you so much to the folks from the Streamlab. This was great. I'm just going to ask you to stop sharing your screen so I can briefly share my screen as we close out today's session. Okay, so thank you so much for joining us today. Seeing a few questions about the recording and slides, so these should be available post-event on our website. We'll let folks know when this is available. Again, please complete that post-event survey. It does help us improve our future events. And if you would like a certificate for professional development, we're happy to provide that. So please email me directly. My email is kallen@waypointcenter.ca, and I'm happy to send over a certificate to you. So thank you so much to today's speakers. This was great. And we do want to share that our next talk is on November 18th with Dr. Carolyn Holding and Dr. Barna Kunkali-Theej. And this will be on transformative climate action in mental health organizations. So you can scan the QR code there to learn more and register. But for now, that's all from us. So thank you so much for joining us today and have a great rest of your day. And go Blue Jays!